Hi, everyone. We wanted to take some time today to talk about some very important issues that we're facing right now in our country. There are a lot of reproductive healthcare challenges and change in laws and abortion bans that have hit this country, and they are greatly impacting women's care. So we really wanted to address it and put it out there. First, we have to say her name, Amber Thurman. She's a 28-year-old woman who presented for an abortion. She had to travel to another state far away. Once she got home, she experienced some rare complications. When she went to the hospital, her care was delayed for almost 20 hours. Now, unfortunately, Dr. Coates and I don't have access to these records. We can't have an opinion on what truly happened. But what I can tell you is that from her family statement, her care was delayed for almost 20 hours. And once she finally was taken to the operating room because she was very sick, that is where she died. She leaves behind a 6-year-old son. And unfortunately, with this story, this was a preventable death.
I think it's important that we all take that moment of pause that we just took, because we know the story of Amber Thurman, but there's so many more young women and women like her who may face these same challenges in the future because of the bans that are happening across our country.
You know what's shocking to me, Dr. Coates, is that when I first heard about this story, I thought it happened maybe last week. It was 2 years ago in 2022. And that just tells you that how many other women have been suffering. And what if we never heard about Amber Thurman? Would we be having this conversation right now?
Yeah, and I think it's unfair if her name, if in any way is being used due to all the politics around it, because at the end of the day, this is a person whose family was affected and whose life was lost. And for us as providers who care for women every day who may end up in a similar situation, I can only imagine what other providers were faced with when they were making decisions around her care. But I'm hoping that we can just use this platform today to help define things that are important for the world to know, because definitions are important, as well as to give examples of things that our colleagues and ourselves have faced just since the overturn of certain policies like the Roe versus Wade overturn. And a lot of you may now know that as the Dobbs decision that occurred in June of 2022 and has impacted the care and access to abortion. And abortion is health care that all women should have access to. And so I am so happy to do this episode with you.
Absolutely. Unfortunately, we both live in states that have been restricted. And there are some states where there are very little restrictions. So there is definitely a disparity based on what state you live in, what zip code you live in. So we really need to have this conversation. So starting with the definitions is really important, because that's the basics, that's science. And that is probably what has really caused a lot of confusion with providers and their frozenness. You know, them feeling frozen and not knowing what to do in situations, because this has never been an issue for us providers in this generation.
Right.
We've not struggled with this before. So it really has impacted the care that we would normally move forward with without any question.
Or hesitation.
And now that we have these definitions that really need to be cleared up so that we all understand how this is impacting women. Okay, sis. So we talked about needing to define these terms. These terms are so important because even providers like ourselves, we are a little confused about where this all fits into the law.
Yes.
Lay people, patients, their families, they're also confused, and just the general population. So let's get to it. The first one we need to define is miscarriage. Miscarriage is interchangeably used with spontaneous abortion and early pregnancy loss. So that second term I noted was spontaneous abortion. It has the term abortion in it. And if you look at many of the laws that are written into place, it has that term. And sometimes it does not exclude this definition of spontaneous abortion, which is a normal, natural pregnancy loss that can just happen in a woman's reproduction.
I have a story. I was taking care of a patient who was denied time off of work because of that diagnosis being in her medical paperwork of having spontaneous abortion. And she was automatically labeled as having some form of abortion and denied time off of work because the individuals at her job thought that she had chosen to do something and that she did not deserve or wasn't deserving of having that time off of work. And so I'm so happy we're taking this time to go through these definitions, because these are a lot of things that our women face, and we have to advocate for them on many platforms, whether that's at their jobs or whether that is in their work, in the workplaces, in their schools. So thank you so much for breaking that down for us.
No problem, sis.
Yeah. So the other one is missed abortion. So that is a diagnosis that a lot of people get confused about because it is an asymptomatic pregnancy loss. So that is another form of a miscarriage where a person comes to the hospital or they come to an office and they are found to still have products of an early pregnancy in their uterus, but there is no heartbeat, but they don't have any signs of a miscarriage.
Mm-hmm. And those patients can show up to your office too?
Yes, absolutely. And that can be very distressing. You know, we just did a pregnancy loss episode for our patients last week. And so I often take care of women at this stage where I diagnose them with a missed abortion, and we talk about management options. Mm-hmm. So we often are sending medications to a pharmacy to help a woman get through or to help treat their miscarriages or their missed abortions. And I have to tell you about a situation which I'm sure you've probably dealt with. Is I sent a prescription to the pharmacy and my patient was denied that prescription at that said pharmacy because that person at the pharmacy did not want to treat an abortion. And it's really frustrating because as providers and as medical professionals who are trying to offer healthcare to all women and individuals as they go through a very difficult stage of life, to make a decision that I want to have medication so that I can end this part of the pregnancy so I can continue on with the next phase, whether that's getting pregnant or being on birth control. That is a difficult decision to make in itself. Then to get to the next phase, to just pick up your prescription after you already experienced a loss, and then you're met with scrutiny.
Yes.
Just to get a prescription after your provider has counseled you. And for someone to say, I am not treating you because this is an abortion. So now you feel like you've done something incorrect or you're doing something wrong when you're just trying to treat your body because you have experienced a loss.
Absolutely. I have experienced this. And it is upsetting and it is traumatic for the patient to have to stand in the grocery store in line fighting with the pharmacist and telling them that they actually have lost their pregnancy.
Yes.
And that is something that can be humiliating.
It is.
It obviously is making people feel shame that is not necessary because they are just experiencing something very traumatic with the loss of a pregnancy. So that can be very upsetting. And sometimes I've had to call the pharmacy, and sometimes you just have to send the prescription elsewhere where you know they'll be treated well.
Yes. And I did both because I am that provider where if something doesn't make sense, one, I'm going to educate you. Because if you don't know what these definitions are, if you don't know why a patient is picking up a prescription, call me as the provider.
Exactly.
Even though that is none of your business. That is that woman's right. That is her privacy. That's her situation that she should be able to deal with privately in her home. I will have a conversation with you to educate you about it. And I did that. And then we just went to another pharmacy, and I'm happy that that patient wasn't met with that same scrutiny and having to explain the situation.
Yes,
but
ma'am.
It's sad that, and it's another example of the delayed care that women around this country are receiving because of situations like that, where people are not using their education, they're using the ideas of other people around them to help them place a a label on other people and refusing care for women. It's really upsetting.
It really is.
Yeah.
And, there are exceptions and clauses in laws and in workplaces that if you have objections to certain things, you have the right to make that decision, right? You have the right to refuse to dispense certain things. But in that same sense, it is also your obligation to have another provider available or meet the patient with compassion and say, your prescription is not ready because I can't dispense it. Can you come back maybe tomorrow to get your medication? Like something like that. But it seems like it has always turned into something really sad in front of a crowd.
Right.
Which is not good for patients and it's not good for the care that we provide.
So an incomplete abortion is when a patient has products that are still within the uterus. So those are products of conception. That could be after a miscarriage. That can be after an induced abortion. And it is termed incomplete because there are still products that are left behind that has not completely been expelled from the uterus. And so during an incomplete abortion, there could be a open cervical os, meaning the cervix is open to show that the products are going to come out, or the cervical os could still be closed.
Well, we're going to go right into septic abortion because I think that ties in a little bit more closely to the incomplete that you just discussed. When you have incomplete removal of tissue from the uterus, that can lead to infection.
Yes.
That is the similar situation to what Amber Thurman experienced. She had a pregnancy still in place that was infected and she got so sick. So that certainly is a life-threatening condition. When we talk about all the different processes here, septic abortion is something that can put you in danger.
Yes.
The next definition we're going to talk about is an inevitable abortion, which now they think it's a little more difficult to pin down and define. And this is where you can get in a little bit of trouble. And I think this is where a lot of people get stumped when it comes to making decisions to move forward with care, to keep patients safe. An inevitable abortion is when you have a pregnancy in place, there likely is a heartbeat, there may not be a heartbeat. You could be in that little window where it's not quite defined yet whether it's a viable pregnancy or not. But the patient comes in bleeding, their cervix is dilated, and the pregnancy sac may even be moving down to the lower part of the uterus trying to get expelled on its own spontaneously. And that is an inevitable because it basically says it's going to happen.
Right. It's just a matter of when. And I know you said this is where providers get in trouble at, but they shouldn't, in my opinion. They absolutely shouldn't, because this is where women are bleeding. Women are showing signs of infection. Women are really, really sick often during these two phases, or can have very severe symptoms, which means us as their providers who are trained in doing these procedures, regardless of what got to that point, we are trained in doing these procedures. You know what the next steps are, which is to operate if this is a woman who has, or a patient who has signs of their blood pressure being a concern. They have signs of bleeding and not being able to have medical or expected management. We know that the next steps is to operate to help that process end faster, because it's in the best interest of that patient, of that woman.
Yes.
Regardless of what the heartbeat may show at that moment.
Yes. However, I had a case just a few days ago, Dr. Coates.
Yes.
It did not fit this criteria.
Okay. I know.
That's where you get into trouble. Now, this woman, she presented to the emergency room with bleeding that had stabilized, but the pregnancy was in the lower part of the uterus, like it was going to expel on its own. I knew if I just sent her home with nothing, that she would probably end up back into the emergency room again.
Yes.
So luckily, the size of the pregnancy actually met criteria to be defined as a miscarriage, and we were able to treat this woman. Yes. But she could have definitely been in that little range where I feel like some people get in trouble. And if the patient is not actively bleeding right then and there, people start to get a little shy about doing the things that we know should be done.
Yes. I think mostly what a lot of providers should do and would do in situations like that, where it gets a little bit muddy, is observe and constantly check in on this patient. And when I say observe, if I have a situation like that, you're admitted to the hospital. I am first call all the time if you have a change in status, whether that is your vital signs, your heart rate, your temperature, your blood pressure. I'm also going to have regular exams for you, whether that is with myself or a nurse if I can't be present, to assess your fundus, which is your uterus, to see if there's any signs of infection, change in pain, change in your bleeding. So when we have those muddy situations, I get that we may have a little bit of pause, right? Because everybody has different situations. You've heard of providers being targeted legally and licenses being up for grabs because they've done something that they thought was in the best interest. And so like you really want to have a little pause. But for me, it's like, I'm not sending you home to figure this out on your own. You're going to be admitted in the hospital, and I am going to be taking care of you during this process so we can come up with a final plan to say, this is when we act because you've had a change in status.
Absolutely.
You know,
absolutely. You're such a good doctor, girl.
Oh, you are too. I've learned from who?
All right. The next one we've got on the list, Doc.
Yes. Threaten abortion. And this one is really tough. I deal with a lot of women, as I'm sure have you, who come in who have signs of early abortion. Those signs could be cramping or pain or even vaginal bleeding. And on the ultrasound, they still have a heartbeat. Sometimes that heartbeat could be a little bit slower than what's normal. Sometimes that heartbeat can be within normal ranges. And their cervix, which is that opening, is still closed.
Yes.
So there is no signs of the products of conception, the early pregnancy, moving. And that can be very distressing because we don't have any medical therapies that I can offer to stop that process from occurring. Right. And that's really hard to tell women. You know, often it's more supporting them through that time, maybe suggesting decreasing work, reducing stress, but there is no medication that I can say, you take this and it's going to prevent this outcome.
So true.
You know, and it's really about 50-50. You know, 50% of those pregnancies can go on to be completely normal, and other pregnancies can result in a miscarriage when those symptoms occur.
Yes. And just like our last video, the important thing is to tell them they did not do this. They did not cause this. There's nothing they can do to make it better or worse at this point.
Yes.
So I think that is still difficult to hear, but it does take some of the responsibility off of them and the guilt off of them.
Yes. And I know we all do this similar things where we may give time off of work around that time. We may recommend no intercourse, nothing in the vagina, just to make sure we're not stimulating the cervix to be opened, you know, making sure you continue to take care of yourself completely, treating your body as if you're pregnant, because you still are. And those are the only things that we have to offer, which is really tough at times.
Yes.
You know, so.
Okay, sis. So the last definition we're going to talk about.
We saved the best for last because
we did.
It's a heavy topic.
It really is. And this last definition is induced abortion. Induced abortion had traditionally been termed elective abortion. Like, I'm electively going to get my nails done on Saturday, and then I'm going to get an abortion on Sunday or Monday or whatever day. And we know as women, as doctors, that induced abortion occurs for so many different reasons, not because you have nothing better to do. It is for many reasons, like social factors. You have no support. Financially, it may not be possible for you to care for yourself, your other children, and another pregnancy. You may have serious medical problems as well. In addition to, you could have a baby that has some severe fetal anomalies that makes that pregnancy not viable. So there's lots of different reasons, and we definitely don't want to minimize it and just say they're electively choosing. There's so many different reasons why women and other people that can get pregnant are making very difficult decisions to have abortions.
And if you look around you, you likely know someone who has either considered or who have undergone an abortion. Approximately 25% of women have experienced an abortion.
I know. And you know what I tell people is that if you walk into the room at church, at school, at work, you count 1 in 4 women in that room have had an abortion. And I don't care what religion you are, what political part you come from, women are women, and they have some dire needs at times that result in their decisions to end a pregnancy.
And also background. There's always this idea that the individuals who are getting abortion are women who are poor or lower socioeconomic status. But over 50% of the women who seek an abortion are women who are mothers already. Mm-hmm. And even a large percentage of those women are women who may be in a relationship or may be in a household or dual parent household. And so a lot of people already place these ideas of what the woman looks like who has sought an abortion or who is seeking one. And they fail to realize that it can be someone that is sitting right next to you who is your sister, your friend, your cousin, mm-hmm. your family member. And our goal is to make sure that women are able to have these services safely.
And you mentioned about people that have partners already. Many times the partner is part of these decisions, which is good because support is given to people. The onus is not just on one person, and it is a decision that many couples are coming to make. So for some of these induced abortions that can get kind of mixed up in the pile with miscarriages and spontaneous abortions, these induced abortions are pregnancy terminations for certain reasons, which we mentioned. And when they are for medical conditions, we know that there are certain medical conditions that are contraindications. Basically, if you get pregnant, you can die.
Yes.
There are certain conditions that have a 50% mortality, a 90% mortality, even a 20% mortality. And it really is up to the woman to decide what is her percentage. That is the deal breaker for her. It shouldn't be someone else.
It shouldn't be our laws. It shouldn't be the government. Choosing pregnancy should be a personal, private decision that happens between the woman and that provider that she's talking to. Because another thing, a lot of people think that the procedures that are offered or the medications that are offered is something that is completely harmful mm-hmm. to the woman and her ability to get pregnant in the future. And I think it's important for us to recognize and to acknowledge that the same medications that we often use for the miscarriages that we discussed on our last podcast, and even the definitions we defined today, whether that's missed abortion, incomplete abortion, inevitable abortion, those same medications and procedures are also the same medications and procedures that are used for a woman who has an induced abortion.
Yes. Do you know where you were June 2022 when the Dobbs decision came down and abortion was banned?
Yes, I do. I was a chief resident. And so a lot of things changed around that time.
It was a hard day.
It's a lot of things that occurred as far as like how we approach certain situations, regardless of what hospital setting you're in, whether that is academic, private, or rural medicine. A lot of people had to think about how they care for women. Where were you? Do you know what you were doing?
Yes. So I was doing orientation for the brand new interns at our residency program. And the decision came down earlier that morning, and there was just a slump with these brand new doctors who were eager to start their new career as physicians. And they knew that this was a time in their lives and their career where everything was going to change. They would not be as well trained when it comes to providing patients with support and care who chose abortion because it was not going to be part of training anymore. Right. And when we think about it, do you want a doctor that's trained more or a doctor that's trained less? Mm-hmm. Any rational person would want a doctor that has seen everything, that can take care of everything, that can manage anything. And at that point, everybody felt that. Everyone in academic medicine felt that it was going to change the way that we are training doctors.
It also was a time where we knew that those women and individuals who already have lower resources and who already have to travel longer distances to seek these services and already who have financial restraints to obtain these services, those barriers just stacked even more against them.
Absolutely. Absolutely. Mm-hmm. And when we think about us, we're privileged because we are now educated. Mm-hmm. We can support our families in ways that our family couldn't do before. Mm-hmm. And if we needed care, if our daughters needed care, we have the resources
to get them that care. Absolutely.
And when it comes to abortion, when people think that it is a dangerous procedure, it is one of the safest medical procedures that we do as physicians.
Yes.
When you compare it to childbirth, even, childbirth has a 14 times higher risk of mortality when compared to having a pregnancy termination, having an abortion. So many different misconceptions that float around regarding abortion care. And we are really, we just need to talk about it.
I just recall, like, as a little girl, I used to hear stories from, like, my parents and my aunts about, from the South, things that they used to hear about other people experiencing to undergo an abortion. And I was trained to be able to take care of women in all aspects of their pregnancy, whether that is continuing care or an induced abortion. And I knew that other resident doctors that come after me will not be able to receive that training depending on where they're practicing across the country. So I remember hearing those things of what other people would do to undergo an abortion in an unsafe manner.
Okay.
Some of those things that I've heard are interesting, and I'm not going to repeat it because I don't want other individuals to seek those things. And I'm thinking, what are we about to see coming into our hospital? What are the circumstances that women are going to go to so that they aren't having a pregnancy that they no longer feel like is something they want to continue with? And how are we as providers going to be able to provide that care for them when they're going to be nervous about telling us things that they may have tried at home or where they have gotten that thing from, whether that is a medication or something else, and how that's going to further impact women mortality in the future? And we've seen it, we've obviously seen it because I know that women have sought out self-management for abortions, right, and that is becoming more common.
Yes. And we're hearing about stories all the time. I know you've heard about stories of women trying to get information on how to follow up if their abortion worked from medications they may have purchased online. I mean, there are a lot of different ways people are trying to find the care. The sad thing is that they don't have a trusted provider that they can go to that can make sure they're safe. So they're winging it out there.
Yeah. I know for me, when I have these conversations with my patients, I am always just reminding them that we're the same team. I am not here to judge you. I am here to provide safe care for you and timely care for you, period. Mm-hmm. And that is just my role as their provider.
Thank you for this conversation.
Thank you. It was long overdue.
It definitely was.
Yes.
It definitely was. There are moments where I really felt like I wanted to say a few more things, but we're trying to keep it calm. Mm-hmm. We're trying to give people information so they can hear us. This is so important.
It is.
This is not fun and games. People are being impacted. They're being hurt. We're seeing deaths, especially with Amber Thurman, and it just makes my stomach turn to think that there are other women that have had the same outcomes that we are yet to hear about.
Yes. And to our viewers, we hope that you take this episode as one where you get the education that you deserve and so need. And it's just touching the tip. It's just the tip of the iceberg. And so if you need additional resources, one, your healthcare provider. And if you feel like that is not a person that you have built a rapport with or a relationship with, that you can have these tough conversations with, find another one. I promise you there's someone out there who has similar ideas as you and will provide the care that you deserve. Also, there is online resources for you. So the National Abortion Federation, we will drop a link. I think we could do that. Drop a link in our episode so that you can seek out appropriate resources and the care that you deserve if you feel like you don't have anyone to have these type of conversations with, if that is something that you face.
Absolutely. That is prochoice.org. Prochoice.org. They are wonderful. They have a hotline that you can reach them after hours, and they can actually counsel you. That is not if you absolutely want to have an abortion. It's if you need support and you just don't know what to do. They're a great resource.
Thank you.
Bye, guys.